Let's start with the session with the unraveling the mysteries of hormone assays. And this was the third class in the ABLE 1 program. I had just swapped between the fourth and third. So today I'll be taking on this class, and these are the certain areas where actually we find difficulties in uh, explaining a report of a hormonal report or endocrinal reports. So let's see an situation where there is some reports where your patient comes to you and really challenges the report, or at least expect that this a peculiar kind of report which the patient has come across, he is not going to believe it, or he is not going to accept it. In that case, you should have a proper knowledge. You should have a proper knowledge to explain that how much deviation has occurred, why this kind of report has come, and for that there are certain knowledges you should have to explain this report, or to explain this hormonal assay properly. So the class is on that particular thing, and since it is a theory class, it doesn't make you feel that, or you may not take home the message that much, which a case report does. That is why we have actually done this. I have actually done this presentation entirely in a case-wise manner. So case by case, we'll explain the things, and on those cases which we actually get the face, we have to face those questions very frequently. So let's start with the case one. So this is our first case study, that during investigation of prolactin result of a young woman have come much higher, about 32 nanogram per TL. Obviously, in that cases, the person is in disbelief and went for a cross check. And the cross check has come 18 nanogram per DL, which is normal. So it's a normal tendency of a patient or any person who actually believes the normal result more than an abnormal result. So now the person came to you and asked you to explain that. That is, I say the prolactin, I started with prolactin. Why? Because prolactin is actually the nightmare of lab medicine practitioners. So prolactin has got so many chances of having variations of so many small things that explaining a prolactin result fluctuation is sometimes leads to almost very impossible. Although your lab has got a very good precision, in both the a time your test result, control results are perfectly fine, but despite of that, you are unable to explain these fluctuations. Why? Because prolactin is considered nightmare, as I already told you. Why? Because they are, this particular parameter fluctuates wildly with certain conditions, which like minimal excitement, no sleep at a minimum excitement, even a sleepless night can increase the prolactin level suddenly. Any trauma, any slightest breast stimulation event, these things can actually release or spark a prolactin release suddenly. So that is why a person having a good sleep previous night will have a normal prolactin. Suddenly having a disturbed sleep may have end up with a very high prolactin next day. And also, there's more to count on that or add on with this trace is that certain drugs are very common drugs like ranitidine, domperidone. That is, how many people who actually take history have taken a PAND or OMAS D something in the previous night, because they're very common drugs. Now, ranitidine, domperidone, these are the drugs very commonly affect prolactin secretion. And that is why these are the things have to be taken care of, and the knowledge should be there that if this kind of thing happens, you should take case history of these minor events, even a sleepless night, a previous dose of ranitidine or domperidone or something. And that is why prolactin, although difficult, but if you properly explain the patient will be more than happy. Now the case study, second case study. I had already discussed this previously also. That a diabetic patient came to you with a A1C 6.2%, fasting 101 and PP 287. Clearly, anybody can say that the PP result is wrong because it is not matching with the A1C. But the thing is that your glucose result of your lab is not a problematic one. You have a good, robust system, and you are doing by hexokinase method or Godpod automated method, which is not possible having such a fluctuation. Where lies the problem? Problem lies here with the patient preparation. And here, actually, your responsibility and the clinician's responsibility both are equal. What happened here, the patient is absolutely controlled diabetic. But on the day of testing, the patient has not taken the medication. Since patient has not taken the medication, the PP result is high. So there are two kind of follow-up of a PP. One is when you do a OGTT PP, that is for a diagnosis of a diabetes. When you need to diagnose whether the patient is diabetic or not, this kind of conditions where you can give some glucose, wait for 2 hours and then do the PP. But when already a patient is diabetic, you are asking for a follow-up, you should give a proper instruction of PP to the patient. That is, you come in the morning, you take the fasting. In the first morning, all the medications which are generally it is given to you. Suppose glimepiride is given before breakfast. Why it is given before breakfast? So that by 1 hour the blood level is achieved, and during lunch, the post lunch sugar surge, it can help continue to pull it down to normal. Now, if on the day of testing you are not taking glimepiride, or you are taking your lunch at 11 o'clock, it will not give you the proper follow-up value, because a follow-up is that where a patient, like all other 29 days, following the same routine and taking all the medications, doing a proper lunch at proper time, and after 2 hours giving a PP sugar. Because what you are doing in a follow-up, you want to judge whether the patient with your medication is within control level or not. Okay, and that is why proper patient follow-up is very, very much important with a proper patient instruction as well. This is how it occurs. That is, always goes with the bolus and basal secretion. Insulin has always have a basal secretion with that, and with every food surge, with every surge of glucose, there is a bolus insulin secretion that happens. So this sometimes this bolus secretion is at fault. Then the patient does not respond to proper meal, and impaired glucose tolerance is seen. But when this patient having a bolus secretion at fault, not up to the mark, you may get a high fasting and PP is not up to the mark, but fasting is very high. That is only because the basal secretion is at fault. So in normal cases, along with that, when we give the medications, they help these basal and bolus and pull the patient to a normal level 2 hours post after every glucose load. So that is why whenever you are testing a patient sample, be very careful of a proper patient preparation. Now, case study 3. This is a very typical example, a very commonly mistaken example. A patient who is actually having a morning empty stomach TSH, which has come 5.9. But he was not happy because it's diagnosing to be hypothyroid. Again, I am saying it's a very common thing whenever you go for practice. Any result which is not up to the mark, which is leading the patient diagnosing to be abnormal, patient doesn't want to believe. In that case, he came again, and you are over enthusiastic person. Okay, you are not sure with it. Have taken the blood sample and tested in the evening. So the report has come 4.3, which sounds to be a borderline normal. Now, what conclusion will you have? Is your first result wrong or your second result wrong? So if you ask the patient to take the second result home, go back home with the second result, then you are actually accepting your first result is wrong. But actually, in both the conditions, you have a good control run. So, what is the conclusion in this case? What you going to believe? Remind, I have to tell you, whenever you want to have a cross check or a repeat sampling, for God's sake, for the hormones, please try to maintain the same time, because TSH is known for its circadian rhythm. It is secreted maximum between 2 to 4 a.m. and minimum at 6 to 8 p.m. So what happened here? During the phase in the morning, you have taken the TSH sample and you repeated the TSH when it is in the nadir condition. So actually your first result was right. But since you ignored the circadian rhythm for TSH and you have opted for taking a repeat sample at evening, so the problem happens here. Now you are in a total soup to explain the situation. So whenever you ask for a repeat sample, kindly take care of it that the circadian rhythm should be maintained, and at the same time the test result should be repeated. Sample to be taken. This is what a very favorite case of mine. A patient with a reputed lab, as my lab, unfortunately, and sore throat, fever, sometimes, and with a condition of a clinically hyperthyroid feature. So I tested that the patient came to be hyperthyroid along with some other CRP high and all these things. And this happened to be one of the very renowned MLA of our state, minister. But unfortunately, during the phase of thyroiditis, good number of thyroid cells are being broken down. So when good number of thyroid cells have been broken down, when the patient is having resolved thyroiditis, 40% of the patient may go to hypothyroid state and 60% may remain in a euthyroid state. So unfortunately, the patient had a significant loss of thyroid cells, thyroid gland cells during the phase of inflammation, leading to a subsequent reduced release of thyroid hormones. So therefore, the patient who actually behaving a transient hyperthyroid post-treatment became euthyroid for a limited period of time. And when ultimately the mass loss of the cells are high, this patient shifted down to a permanent hypothyroid patient. So this you need to explain the patient with fullest of your confidence and belief. Then only you can come out of this critical situation. So that is why to having a proper knowledge of the entire scenario is the most important thing when you are going to sign or when you're going to interpret a hormonal result or an endocrine result. Now it is a case study 5. An athlete appeared for a dope test, a slightly short height patient. Growth hormone tests are coming very high. Now what is the problem? The growth hormone is coming high. Now I'm totally in dilemma because investigation showing that everything is normal, but the patient is having a history of smoking. But now it's a dilemma is how difficult it is to interpret. You cannot say the patient has has done dope, because dope can also release a growth hormone transiently. And believe me, a few cigarette smoking can also cause a transient 30-minute rise of growth secretion, Rh hormone secretion, near about 10 times of its normal range. So this is a typical example of smoking can actually jeopardize the entire interpretation of your growth hormone diagnosis. Now you cannot say the patient whether the patient has doped or the smoking has caused the increase of growth hormone release. So these are the very important things you have to take care of. Whenever you are asking for a growth hormone testing, please refrain the patient from smoking before the blood sample is taken. Another very interesting and very important, I think a lovely case of one of my most favorite. ACTH assay is done for a patient for differential diagnosis between a Cushing syndrome and Cushing's disease or primary adrenal tumor or ectopic ACTH. Sample, since ACTH is not done in regular lab, the sample was sent in a reputed lab. But the result came very confusing. The patient having high cortisol, but the patient having almost zero ACTH. Now, this condition with a suppressed ACTH and a high cortisol goes in favor of what? Goes in favor of a primary adrenal tumor secreting cortisol. But unfortunately, no CT evidence, no radiological evidence of any adrenal tumor was found over there. So patient, doctor is totally confused because a high ACTH and high cortisol would have given him the diagnosis of Cushing's syndrome. But in that case, now I'm confused whether it is a primary adrenal tumor or not. The confusion arises, and the result is what is leading to that. Whether should I say it is a Cushing syndrome or not? I cannot say that because just because. Why is it so? Is it because no clinical condition? Rather, you have to understand the ACTH result is low because of a false or bad collection and storage. Whenever you are doing a plasma renin activity or ACTH study, you should understand or you should keep in mind ACTH is very easily oxidized and absorbs to glass surface. It is rapidly degraded by plasma proteases and extremely heat sensitive. So what we do, we actually send to Delhi or Mumbai referral labs from our lab. We don't at all take care of these things. One of my reputed chain lab who was actually taking samples from my hospital was taking plasma renin activity, and I said to that person that how can you do a plasma renin activity of a patient held back to the Mumbai when the flight and cargo will take it for no less than 8 to 10 hours. They say it is possible, it can be done. I said, kindly note the patient's name is Mr. Birla. Then said, better you don't send it. That is the thing, because normally you don't cross-check these results. But maybe the lab is doing the results very well, but by the time it reaches the lab, there is nothing left of that parameter. It have already been degraded. Here also happened the same. ACTH was totally degraded, and what you got a zero ACTH and came to total jeopardized condition of the entire problem. So whenever you are actually sending ACTH to anywhere, you have to keep in mind all the things. No prior administration of any steroid group of drugs, no stress, and blood specimen should be collected in a polystyrene tube containing EDTA and a protease inhibitor, that is aprotinin, and antioxidant markup to ethanol immediately, and it placed to ice and keep it at minus 20 degrees centigrade temperature by aliquoting and send it at minus 20. Then and then only you can get a good result about ACTH. Otherwise, you only send the sample, you don't get a good result at all, because ACTH by the time reaches the lab, it gets degraded. Now another case study again. This is a case study of a prolactin normal report of a patient. This time the woman having a CT of brain and MRI also. This shows an adenoma of pituitary gland, having a pure milky discharge of the breast and amenorrhea. So every possible sign of a hyperprolactinoma. But repeated in testing, the prolactin is coming normal. So how would you explain this? It came to me. So what I have done, I have just diluted the sample in 1:100. The result came as 156 nanogram per ml, far higher than we expect. So this is a classic syndrome of hooking effect, or you can call it a Poisson phenomena. When there is an antigen excess or antibody excess, it was mostly antigen excess. It actually leads to total Poisson or excess hooking effect, so that the antigen antibody complex formation is totally jeopardized, and your result actually coming, which is immunoturbidimetry method, your result is coming to be a very less, because the prolactin saturates the antibody binding sites, and therefore no sorry, no antigen antibody complex formation at all, leading to a very low result of a 10 or 5 something. But the main factor is that when I have diluted the sample, the hooking effect was gone, and now I am getting the best result. So in those cases where you are actually, patient is clinically hyperprolactinemia patient, but your results are normal, please do take care of this and please consider it to be a hooking effect and dilute the sample and do the result once before leaving a normal result. So these are the very tricky things you have to keep in mind whenever you are releasing the report. Now again, I am coming to a sugar. This is a funny example, very funny example. So elderly couple has come for sugar testing to my lab. Husband diabetic, wife non-diabetic. So now in elderly patients, usually whatever they do together. So both decided that they will do fasting and PP. Now husband has done PP after lunch, taking all medication as scheduled. That patient a long-term patient, so never done any mistake. Now wife also very keen to get stamped diabetic along with her husband. So she has done a PP with 75 gram glucose. Done fine. She has no history of diabetes, mind it. Now the result of husband came as fasting 122, PP 156, A1C 6.1. Pretty good. Understandable, more or less control. Wife result is A1C 6.2%, fasting 118, PP came 42. What is the first thing will be on your mind? Probably it's a case of sample swapping. Probably the husband and wife has swapped the report samples. So I immediately called up that person just to ensure that your sample is swapped, so no problem. Don't worry. I was very apologetic when I was calling that person. I was surprised. Husband picked up the phone and said, "Yeah, I have no problem, I'm fine. But my wife is actually a bit drowsy since the blood sample has been given. Now she is sleeping." So I got totally dumped with this, dumped with the dumping syndrome. So immediately ran. Fortunately, there were some serum samples also. I've done insulin. PP insulin of that lady was very high. This is a typical case of dumping syndrome. This kind of patient, they react abnormally with a sudden load of glucose. So actually exorbitant release of insulin happens suddenly, leading to pulling down of the blood glucose and a sudden hypoglycemia post sugar. Now this has happened most of the cases in dumping syndrome. Patient is coming to you with a very hale and hearty condition with a sugar of 32 because of constantly every day they face this kind of hypoglycemia and remain to a hypoglycemia unawareness. And the damping syndrome is more acute if more fast sugar load you are given. That is what happened to this lady. Lady is not an exact dumping syndrome patient, but since she was given a load of sugar over there, so suddenly there was a jump of insulin with a sudden load of sugar that is given in OGTT with 75 gram, and that is why the patient was also looking sick and was drowsy because that this particular case is not a typical is given. So this is happened of this particular patient with a sharp rise of insulin and a sudden hypoglycemia. But I remind you, in cases where you can get classical dumping syndrome, particularly post gastrectomy or other cases where you find those patients may not feel this kind of symptom every time they have a uh, good load of food. So they may remain hypoglycemic unaware because every day having hypoglycemia. So the main caution thing is that the patients need to take food in a very small manner, not in a good heavy amount. Whenever the patient takes a heavy amount of food, hypoglycemia ensues. This is a very typical condition, atypical condition, but I think everybody should keep in mind. And whenever you find such a case, please corroborate with serum insulin. This is another typical example, a very, very interesting case. A patient was admitted to hospital for 2 months with chronic illness. Now, after this chronic went back home, suddenly there nowadays you will find that in 1,000 rupees I will do everything, every possible case of yours from tip to toe, if possible MRI. So this kind of some package he has opted, and he has tested just after going back home. He was only asked to test for urea creatinine or something, but he has done a hell lot of tests and went to a physician for checking. The classical report of a hypothyroid patient with a low T3, T4 and a high TSH. But fortunately, the physician did not give him any medication and asked him to do the testing after 1 month. Why? Because he is fortunate that the physician is very good physician. This happens very typical case of a non-thyroidal illness or sick euthyroid syndrome. So anybody who is a chronic illness just recovered from, please for God's sake, unnecessary don't take the thyroid tests. What happens in this case? TSH usually decreases in the initial phase, but increases during resolution phase. But T3, T4 all remains decreased phase. This is, if you see the graph, it looks like that. Throughout the period of illness, reverse T3 is excessively released, but this RT3 is unmeasurable, so we cannot measure them. The T3 and T4, both of them has a deep decrease phase. T3 always remains in a decreased manner. But the most fatal condition is during the early phase of recovery, during this phase, if by chance, if you draw blood sample, it will show a low T3, low to normal T4, and slightly above TSH. You cannot deny it a case of hypothyroid. But the patient is not at all a patient of hypothyroid. This is condition, a very transient condition of sick euthyroid syndrome. That is why whenever a chronically ill patient comes to you with such a report, for God's sake, ask the patient to repeat after 1 month. Otherwise, you are misdiagnosing the patient, giving L-toxin to that patient and unnecessarily making the patient hypothyroid. So this is, although uncommon, but not so uncommon. Please keep in mind whenever you are interpreting such results. Last is not that classical a case. Nursing staff admitted with a CBG 11 milligram per DL. We have given 25 dextrose followed by IV 5% dextrose. Patient non-diabetic, no significant family history, but disharmony in marital status is noted in the history, so that is significant. No abdominal CT findings, abnormal CT findings in abdominal cases, because if you think of these conditions, insulinoma first to rule out. Consultant physician call me up and say that you have to advise how to rule out insulinoma, because should I do insulin? I should not do insulin. What I should do then? I should do a C-peptide. What is the logic? Because if you do a serum insulin, and if the patient have injected insulin by herself, she is a nurse, you have to take out the possibility of a injectable insulin and excessive insulin overdose versus insulinoma. So who will be able to rule it out? C-peptide, because insulin will be high in both externally administered insulin and insulinoma, but only in internal insulin. With each unit of insulin, 1 unit of C-peptide is produced. So in case of external insulin production in a dose, you will not get a raised C-peptide. Only in case of a high insulinoma, where insulin is secreted from inside. This is a condition, this is a proinsulin. Now when proinsulin breaks down from there, you get an insulin and you get a C-peptide. 1 unit of insulin releases 1 unit of C-peptide. So if you do C-peptide only, you can differentiate between insulinoma and externally administered insulin. So this is the condition where you should ask the physician to do a C-peptide test. Now, how hormones are different from other analytes? In a nutshell, now I'm going through. So they are affected by so many things: posture, circadian rhythm, exercise, pulsatile nature of release, lifestyle, drugs, storage, and transport. So first we talk about posture. Change in posture in line to standing increases secretion of catecholamines, aldosterone, angiotensin to ADH, etc. Epinephrine and norepinephrine double the things in 10 minutes. Prolonged bed rest can reduce the circadian variation of several hormones, reduce the urinary excretion of aldosterone as well. If we talk about strenuous exercise, excessive strenuous exercise increases renin activity, stimulates cortisol secretion. Normal diurnal variation may get abolished because of exercise. Excessive exercise, suppose you are doing it. So anything stress, cortisol responds to stress. So if you exercise high in the evening, the stress level is high in the evening. So then maybe you are getting a low cortisol secretion at the evening, but in case the diurnal variation may be lost, you get almost similar kind of cortisol secretion at daytime. Similarly, aldosterone, growth hormone, and prolactin may also be increased with exercise, strenuous exercise. Now, you talk about circadian variation. As I have already discussed, cortisol, as all we know, that they have a highest part between 6 to 8 a.m. and lowest between 4 to 6 p.m. Similar are seen in growth hormone, epinephrine, aldosterone, plasma renin activity, and also, as you say, TSH level, maximum between 2 to 4 a.m., minimum between 6 to 8 p.m., and the variation can be as high as from 50% to 206%. So, circadian variation you always keep in mind when you are interpreting or testing a hormone. Next, this is another very typical example. There are certain hormones like lutein, LH, FSH, and prolactin. They secrete like in a pulsatile manner, once at a time in a bursting manner. So sometimes half an hour before there is a pulse burst, you get a high result, half an hour later may not. So in those cases, it is always advised to take a pooled sample of minimum 3 samples taken at 30 minutes interval, mix the samples and then run to get the right result. So these which actually secrete in pulsatile manner, those hormones always preferable to get a pooled sample result tested instead of a single sample. Now there are some pre-analytical factors like caffeine intake can increase secretion of epinephrine, PRA. Smoking, as I have already told you, increase GH secretion. Alcohol can increase plasma aldosterone concentration and prolactin also. And to be a very important, there is a sharp reduction in testosterone in male. So you have to choose whether you go for alcoholic nature or not. So this is a very interesting finding for male. Anyway, so next other factors like OCP that stimulates estrogen-induced synthesis of hormone-binding proteins. So therefore, if the person is having OCP, the high sex hormone-binding globulin or high TBG may lead to a false elevation of glucocorticoid, sex steroid, or thyroid hormones. Similarly, prolactin secretion may be affected by dopamine, as I have already told you that all these dopamine antagonists or antihistaminic drugs, and phenytoin, who actually competes with T4 or with the thyroid binding globulin. So therefore, if phenytoin is administered, you may get a low T4 because T4 cannot get bind with TBG or TBPA. As I already told, certain hormones, the ACTH or renin, are extremely sensitive, so storage is a very important feature for them. Now, in a nutshell, you have some pre-analytical factors which are crucial for the following hormones, like insulin, where a meal timing, sample draw timing, medication is important. For growth hormone, lifestyle or circadian rhythm, you should keep in mind, obviously smoking. TSH, time of sample draw, medication, cortisol, keep in mind circadian rhythm and medication. ACTH and PRA, specimen collection and storage to be taken in consideration. For prolactin, body stress or stimulation and other drugs to be taken in consideration before you interpret the results of them. So I would like to invite questions. Thank you for patient listening. I'd like to open the session, and anybody can take the questions, please.
So there are two questions in the chat.
Yeah, please.
One is regarding dilution, and another one is regarding sick thyroid syndrome.
Just a minute. Can I take a phone call? It's coming several times.
Sure.
Make me mute for a time. Now keep my things open. Okay. No need for this.
Anybody has any question can either type them in the chat box or they can just ask. I think people are typing. Sir, you are on mute.
Yes. Please tell me the question once more. Yes, is fasting needed for testosterone analysis? Fasting is not needed for any analysis other than sugar and triglyceride. Can we do dilution beyond the limits recommended by manufacturer IFU? See, again, I'm saying whenever you are doing a dilution, so there are two particular conditions you must remember. One is called AMR, actual measurement range or analytic measurement range. And second one is called CRR or clinically reportable range. So the maximum dilution range, the maximum dilution is actually evident for AMR mainly. That is, after an AMR ends, you can do a maximum 1:20 dilution. But there are conditions where CRR is very important. The clinically reportable range. This happens for few parameters, not for all. Suppose in case of potassium, a patient does not live or unable to live with a potassium 9 to 12 or something. So if you get a potassium more than 6 or more than 7, so is there any utility of diluting the sample for some higher potassium level? No, I don't think so. But there are certain parameters like beta HCG where you have to answer beyond, you have to give the result beyond your AMR level. For beta HCG, maximum possible of dilution you have to carry out. Why? Because a 2 lakh beta HCG may be a diagnostic for a pregnancy. 20 lakh may be diagnostics of, 2000 may be diagnostic of pregnancy. 20,000 may be diagnostic of a hydatidiform mole. But a 20 lakh may be diagnostic of choriocarcinoma. So suppose a patient having choriocarcinoma and coming to a follow-up to you after chemotherapy, a reduction from 20 lakh to 2 lakh is very clinically significant. So you have to understand which are the parameters which are clinically significant and which are the parameters which is clinically not significant to go beyond dilution of protocol. There are certain conditions where a result going beyond protocol dilution sometimes give clinically important value, so you can go. Otherwise, what happens if you go up to a recommended dilution or beyond that, the sample loses its matrix nature. Excessive dilution by water, the matrix of the sample is actually getting changed. And that is why there is possibility that you may not give a right result. Okay. Does T3 gets lower in elderly? Likely. Because it doesn't get lower in elderly, but the peripheral conversion may get lower. Anti-TPO is a true tool of diagnosis. I personally don't believe so. Anti-TPO is raised whenever there is an inflammation in thyroid. So it can be an it is a antibody against thyroid, or is a generalized condition previously happened because of hypothyroidism. TPO, whenever comes to blood, will release an antibody. So anti-TPO for me, I'm not the perfect person to say that, but to me, anti-TPO doesn't carry a very high importance in clinical diagnosis of thyroid. Do hemolysis affect hormonal studies? Sometimes they do, but mostly not. We get a high FBS and ppbs with values very close to each other. Sometimes FBS higher than ppbs. In those cases, by very good question, Dr. Suman Pandey, this very commonly happens. Sometimes you get a higher fasting and lower pp. I have seen people swapping the results, but please don't do so. It is totally possible, because the persons who are, I have already told you, the basal and bolus secretion difference of insulin. So some people who are insensitive to glucose load, they cannot react to glucose load that fast, so they have a high pp. We target those patients pp sugar by giving either voglibose or something which reduces glucose absorption, or we can target with a glimepiride, or we can target with now empagliflozin. With those cases where pp, we need to reduce the pp by any means, because the person main concern is they cannot, or they cannot go against the glucose load. That reaction of insulin is slow or inadequate. But there are conditions where the basal secretion of insulin is not up to the mark to overcome the hepatic glucose output, that is mainly happens in neoglucogenesis or glycogenolysis. So those patients tend to have a higher fasting plasma glucose. So high fasting plasma glucose and less than normal pp sugar may also can come in those cases. If there is no mandatory thing that FBS has to come always low, particularly in those lean diabetic patients, I have seen high fasting plasma glucose more than pp, because they have a high hepatic glucose output, they have a more neoglucogenesis, and a basal insulin secretion very dampened. So those patients can have a high fasting and almost near normal pp. Any kind of thing is possible. IFG is possible, IGT is also possible. So you have to keep yourself open, and you have to judge the patient with an open mind. There is no such rule that fasting has to be lower than pp. So this is, which is a better parameter, total T3 T4 and F. Nowadays Harrison has clearly mentioned that whenever you are actually following up a patient, is best way to follow up with FT4 and TSH, because free T4 is always a much better one than total T4 at any point of time. Sir, we need to do FSH in day 3 of menstrual cycle. FSH, all the conditions of FSH and normal ranges of FSH, they are as per the day of menstrual cycle. So whenever you are reporting, you should report on those conditions. Premenstrual part, postmenstrual part, sorry, I mean early menstrual phase, ovulation phase. So accordingly, the reference ranges are given. Whenever you are actually reporting an FSH, please do take care of that part. I think I have already answered all of you. So whether this video is available on YouTube, I think I am not the best person to answer. ACCLMP official will give you the answer. Probably it will be there on YouTube. Uh, Yeah, why T3 gets lowered in critically ill patients? So that is mainly total T3 gets lowered because in chronically ill patient the proteins are released, protein are less produced. Number one, peripheral conversions are more. That means total to free is more. And without knowing it in a detail, I cannot answer you properly. But so far I know reduced protein synthesis may be one of the reasons for that. Can we have more of these web meets? That is Dr. Vinita Goswami is the answer person because she is the leading person of this concept. She will be saying the thing. She can answer it to you whether we will get more and more web meets like that or not. Personally, I would like to have such a web meets very frequently. Oh, again.
I think for the question that was regarding the web meets, yes, definitely we're going to have more. Now we'll be shifting on to the module 2 of the ABLE course, which is on molecular biology. And after that, we can have some more sessions on clinical biochemistry. I'll be letting you know, I'll be sending the links and you can join in. The month of December is dedicated to molecular biology, where we'll be discussing starting from inheritance till NGS, along with classes by people who are actually reporting patients. Regarding, there was another question on the recordings. I think 2 of the first 2 lectures are already on YouTube. The case presentation, which was taken by Dr. Mala, I will be sharing the PowerPoint presentation shortly. And these 2 lectures by Sir, as soon as the recording is finalized, we'll be putting it on YouTube. Sir, you're on mute.
There's another question have come. The last one, yeah. We need to report TSH after dilution. I personally believe up to 150 you should report because whenever the patient will be started eltroxin, suppose a patient came with a report of 200 or 150, and after starting eltroxin, the clinician would ask the patient to come back after 1 month. So if the patient comes with a report of 60, that means a very clinically important information that this is not up to the mark, but I have to increase the weight. It's just like testing TSH and weighing a product against weight is almost similar thing. Matlab, if you just go to any market, how a thing is weighed. First, you keep the measurement, and then you put on the measuring stones on that, so that whenever they are getting balance, that is the dose. So similar thing happens over here. We measure with the TSH. We put on this electroxin dose and measure with TSH. Whenever TSH comes to a normal level, that means that is the reduced dose or that is the dose gap of electroxin or thyroxine which I have added from outside. So similarly, when you report a 200 TSH, it helps us whenever we are doing a treatment, whenever we are asking the patient to come back next month. If the patient report is 60 also, it's a clinically slightly improved status, which helps us to decide that I have given the patient 50 microgram thyronam. Now I have to give it 75. 100. I'll straight go with 100 microgram because for that patient, even 50 microgram work nothing. So my dose reduction or dose increase, everything depends on whatever reports I am giving. So I would personally believe that at least 150 to 200 you should give the result.
I think, sir,
So
the
I think
questions
I
are
think from the
all
last,
covered up.
yeah, I think all covered up, and I think people actually like this particular lecture most among the 4. And looking at the number of questions I'm getting.
So thank you very much, sir,
So
for
thank you.
taking time out. And
Yeah.
thank you, the participants also, for making this a success module, and we'll rope in sir again for some of more case discussions after the annual conference is over. Thank you,
Yeah,
sir,
and
and thank you,
I'd like
everyone.
to thank you a lot for such a wonderful thing to conceptualize. And I think these are the clinical things have been taught over here. Now more and more finer and more sophisticated things will come up in next module. And lots of very good speakers are there. Really academically brilliant teachers will be there. Speakers will be there. So all the best for the coming module. And I would like to actually congratulate ma'am for not only congratulate, I'd like to thank you because to give an opportunity to a non-teacher like me to teach so many people for so many days. Thanks a lot.
Sir, I've learned so much from you. Thank you so much. Thank you for finding out time. Thank you, everyone. Good day and goodbye.